Thank you, everyone. These are our disclosures. Dr. Madani has a few disclosures. The other authors have no disclosures. None of the disclosures are related to this study. So as you have seen, and as Dr. Gerald has also mentioned over the last couple of days, we've learned that computer vision and deep neural networks these days have now made it possible for algorithms to correctly identify surgical phases and steps in surgery in near or real time. We ourselves have developed an algorithm called Go-No-Go-Net, which can correctly identify safe and unsafe zones of dissection in a laparoscopic cholecystectomy. And although this and other algorithms like this do exist and have been accepted as proof of concept, their actual role in surgery and in clinical practice training has not yet been defined. And that is what our purpose has been. We are trying to set out to define what the role is. So for that, we have decided to elicit the opinions of surgeons and trainees, residents and fellows on the educational value and clinical utility of this tool. We use the Decide AI framework to guide us. Participants were selected from our center. Attending surgeons, fellows, and residents participated. We developed a web browser device agnostic interface so that we could deploy GoGoNet in the operating room. The implementation, the study was done in two settings. One was the synchronous setting, which was in the intraoperative, where the feed was picked up from the surgical tower and through a separate computer was uploaded to the cloud, where Go-No-Go-Net did the analysis and gave back the video feed relay in real time to the OR, where it was displayed to the surgeon on a separate screen. In the post-operative setting, which was in the asynchronous mode, the participant would take a pre-recorded video and upload it through their computer to the cloud again, and the Go-No-Go-Net would prepare a video for analysis, analyze it, and keep it ready for download, which they could view at their own convenience. After all the participants viewed the video, they would be given a link for a survey. The survey had questions which asked them about the clinical value of this tool. Questions were based on agreement, Likert 5-point Likert scales were used, and some other questions based on the usability were also asked. Our results, the demographics. We had a large number of men and women who participated. The minimum age was 25 and the maximum was around 52. We had the experience ranged from first-year PGY1s to all the way to attendings who had about 15 years of practice, who had done 1,500 surgeries and were doing about 150 a year. When it came to familiarity with AI, you can say on overall, about half of them were familiar and half were unfamiliar with AI. On the questions on the educational value, the intraoperative participants did feel that it really helped for real-time coaching and improving confidence. 70% felt this way. When it came to decision-making and surgical performance, they were slightly neutral about it. The participants who did the post-operative study did feel that it was also useful for post-operative coaching, and overall, all the participants felt that this would be beneficial for patient care. When it came to teaching and whether they would integrate this into their coaching studies, the participants of the intraoperative and postoperative were both generally positive and had a high degree of agreement. We asked practicing surgeons whether they would incorporate it into their actual schedules and how far they would go with it. Many were more keen on the post-operative version, where they would do it in a post-operative setting. For the intraoperative, they were still a little undecided. We asked them whether they would use it consistently. This did not yield any clear results. In the usability, what was encouraging was that 80% said that they were quite happy and they didn't feel any time lag and that they were happy with the screen resolution. Only about 50% felt that they were not completely happy with the OR workflow the way it was going. And overall, the results, everyone said it was easy to use. That was most encouraging. It was not complex to interpret, and it would be an effective adjunct for surgical training. We asked a few questions on design, and most importantly, everyone wanted a human in the loop. They all wanted to be able to turn it on and off at their discretion. That was the most important finding there. We also took some open-ended feedback, and what was interesting is some felt that there might be dependence in some time, where they feel that trainees, if they're exposed to a technology like this very early in their career, they might get a little too dependent on it. That was a concern. Another candidate found that Maybe because his case was too easy, he didn't find it too useful. But generally, one candidate said that for a difficult case, this would be a really good tool to have. We had quite a few limitations to our study. It was only done at a single academic setting. Our sample size was only 20. The algorithm has shown some biases like an instrument bias, but we are trying to overcome it with some optimization measures that we are still in the process of developing. We're also planning a large multi-center qualitative study which will explore opinions of other users. And overall, in summary, the preliminary results are very encouraging, and we are going to further get the opinions of other stakeholders like nurses, clinical staff, non-clinical staff, and all the others to further elicit the role and to define the role. Thank you.